and we're going to turn it over to Dr. Neil Clancy from the University of Pittsburgh, who's going to be discussing Candida Diagnostics. Neil?
Thank you, Dr. Ostrowski. What do you see? Do you see my slides?
We see them perfectly well.
Okay, a single slide. Okay,
Yep.
Very good. Well, thank you. Thanks for the opportunity to participate. Thank you, everyone, for joining us. I'll talk about Candida Diagnostics. Is the slide advancing? It's not on my screen. There it is. Okay, just a quick disclosure. I will talk about the T2 Candida diagnostic test. I've been a clinical trial investigator and served on ad boards for T2 Biosystems. So let's start with a case. This is a 65-year-old man who underwent a right extended hepatectomy at our hospital with a Roux-en-Y biliary reconstruction and a colodocoduodenostomy for what ultimately proved to be a non-malignant hepatic mass. So with this surgery, there are 2 anastomotic sites that are predisposed to leak and potential complications postoperatively. Our patient initially did well postoperatively, but about 2 weeks after surgery, he developed fever and worsening leukocytosis. And here's the scan that was done at that time. He's lying on his back. You can see the white contrast dye. And within the red circle here, this little bird's beak is where contrast is extravasating from his small intestine into the perihepatic region. So he's got a complicated peritonitis and an evolving perihepatic abscess. This undergoes abdominal washout and surgical drainage. And the question for the ID team is, should an antifungal agent be instituted in this patient? And each center probably has their own approach to these type of cases. At the University of Pittsburgh, these patients standardly would be treated with antifungal agents. So our patient got started with fluconazole, and then data are collected and begin to come back. So within a couple hours, we get a serum T2 Candida result, which is positive for Candida albicans / Candida tropicalis. And then over the next day or two, you begin to get abscess and blood culture results back. The abscess culture is positive for E. coli and VRE, but negative for Candida. And the blood culture also has the E. coli, but is also negative for Candida. So, the question then is, what is the likelihood that this patient has invasive candidiasis? And, you can consider anything from very, very low likelihood with the negative culture results to extremely high likelihood. Our critical care colleagues usually just want to know what to do and don't want us to discuss how we get there. But I'll return to this case a bit later in the presentation. But when you consider any diagnostic test for invasive candidiasis, the first thing to think about is, what type of candidiasis are you trying to diagnose? And if we consider the spectrum of invasive candidiasis, we have bloodstream infection, candidemia. About half the time, candidemia will clear spontaneously, even without antifungal agents. But the other half of the time, you end up with candidemia complicated by end organ infections through hematogenous dissemination, or deep-seated candidiasis, DSC here. And then there's a third entity, as in our case, where you get Candida introduced directly into a normally sterile body site, such as the intra-abdominal cavity. And 20% or fewer of these cases will have a secondary candidemia, but most of these are primary deep-seated infections without bloodstream involvement. So if we go across the spectrum of candidiasis and we look at blood cultures, if you're actively candidemic and a culture is drawn at that time, you're going to detect almost all of those cases. However, candidemia complicated by deep-seated candidiasis, blood culture sensitivity is only on the order of about 40 to 50%. And part of the reason for that is a lot of these are relatively transient bloodstream infections with then more longer-term organ infections. And if you don't collect while Candida is in the bloodstream, you'll miss these cases. And as I mentioned, most cases, 80% or more of primary deep-seated candidiasis are going to be blood culture negative. So across the spectrum, the sensitivity for blood culture is 50 to say 70%. And moreover, blood cultures are limited by slow turnaround time and turning positive relatively late in the disease course. Now, how about if you do a biopsy at the site of deep-seated infection rather than test the bloodstream? And here sensitivity again is only about 40 to 50%. And part of the challenge there is finding the Candida amidst a large body of uninfected tissue. So it's these data that have led to the need and the desire for non-culture diagnostics. I'm not really going to talk about the Candida albicans germ tomb assay or combined man-an, anti-man-an assays. These are used to varying degrees in Europe. I think the data on these would suggest that performance is generally similar to or perhaps somewhat inferior to that of serum beta-glucan. So the beta-glucan assay that's FDA approved in the United States, of course, is the Fungitel assay. There's a large body of literature, a lot of data out there, but these are limited really by the heterogeneity of studies. And it's a bit of a morass to go through and really understand what the performance of this assay in across populations is. But if you look at meta-analyses that have been done for bloodstream candidemia infections, generally sensitivity ranging from 60 to 80%, specificity about 80% across studies, with somewhat lower sensitivity and specificity for deep-seated candidiasis. So remember, this is a non-specific assay. It will detect other fungi. It will not give you species identification for Candida. And it's also limited in the real world by slow turnaround times. These are often batched or send-out tests. PCR, there's no FDA approved PCR assay in the United States. Moreover, unlike Aspergillus PCR, the work Dr. White and others have done in Europe, coming up with standard PCR assays for Aspergillus, we don't have that in Candida. This is even a more heterogeneous literature than the beta-glucan literature. Sensitivities for candidemia generally in studies from 70 to 90% with high specificity. And as you can see here for deep-seated candidiasis, really sensitivity and specificity that are all over the map. So you really need to know the assay that you might have access to. T2 Candida might be considered a combination of a nucleic acid amplification assay with T2 magnetic resonance detection of the amplified product. It's performed in a self-contained desktop unit if you have a large enough desk. It detects the big 5 Candida species that at most centers account for 95% or more of invasive candidiasis, and results are reported, as in our case, as positive for albicans or tropicalis, and or positive for Candida parapsilosis, and or positive for Candida glabrata or Candida krusei. There is an add-on Candida aureus assay that exists as well. So candidemia sensitivities and specificities in clinical trial, sensitivity was 90%. However, in the emerging real-world usage, sensitivity for candidemia probably more in the 70% range, plus or minus, but retaining in real-world settings, as in clinical trials, excellent specificity. Sensitivity for deep-seated candidiasis, probably more on the order of 40%. So again, a bit lower than what you see in bloodstream infections, while maintaining excellent specificity. So I think the key to any of these is knowing your local test performance, knowing your local epidemiology, and knowing how you would expect the test to perform at your center and in your patients. So when we actually use tests in clinical practice, we're not so much interested in sensitivity and specificity as reported in the literature as we are in positive and negative predictive values. So what's nice for candidiasis, candidemia, and deep-seated candidiasis, abdominal candidiasis, is we know from various studies over the years in given patient populations what the rough prevalence of invasive candidiasis might be. So if we look at candidemia, any hospitalized patients who you get a blood cultured in, about 0.5% of those patients are going to have a positive blood culture for Candida. If you go into the ICU, patients with fever, about 1%. ICU patients with sepsis, septic shock, about 3 to 5%. And then if you use one of the prediction scores that are out there, such as Dr. Ostrowski's MSG prediction score, you might be able to get a pretest likelihood or prevalence of disease of about 10%. And similarly, among cohorts at risk for intra-abdominal candidiasis, you can go from low-risk groups such as peritoneal dialysis patients with peritonitis who will have about a 5% prevalence, all the way through high-risk gastrointestinal hepatobiliary surgery, biliary leak, gastric or duodenal perforation patients in whom the prevalence might be as high as 30%, and then intermediate groups as well. So then if you know your pretest likelihoods or your prevalence of disease in various settings, and you know your approximate test performance characteristics at your center, you can then calculate the positive and negative predictive values in various populations. And as your pretest likelihood increases, your positive predictive value will increase and your negative predictive value will decrease. So here's an example of data that you might expect for candidemia risk cohorts. And what you can see is for candidemia across prevalence of disease, your negative predictive value generally remains very, very strong. However, for these low prevalence diseases, you're already starting with a very low likelihood of candidiasis. So in effect, your starting negative predictive value is very, very high. So how are we going to use tests like this then in clinical practice? And a big challenge in the fungal world, and particularly the candidiasis world, is we don't really know the disease thresholds that are sufficient to trigger antifungal treatment. So if we go to the old hematologic malignancy critical care literature, it would suggest that antifungal prophylaxis is effective in preventing invasive fungal infections if baseline rates are greater than or equal to about 15 to 30%. So then we might take this as a target that could justify antifungal therapy, in which case we want to get target positive predictive values greater than or equal to 15 to 30%, with corresponding negative predictive values that remain in the upper 80s or 90%. So if we look at a Fagan plot here of pretest probability of invasive candidiasis in the black line, we can see increasing pretest likelihood as we go across our various risk groups. And then if you add on a positive non-culture test, you'll increase the post-test probability, shown here on the y-axis, to the corresponding blue line. And if we say we want to have a 30% likelihood that would justify empiric or preemptive therapy, our objective then is to go from below the red line with a positive test to above the red line with a positive test. So what's important to understand then is that any of these non-culture tests are going to have a window in which they give you potential value. If the pretest likelihood is low enough, a positive predictive value is probably not sufficient for you to use that test to justify treatment. Conversely, if you have a high enough pretest likelihood, a positive test may increase that. However, you're already starting with a pretty high likelihood, and a negative test now is limited by a lower negative predictive value, and in fact, may be too high for you to feel comfortable not giving antifungals. So let's go back then to our candidemia MICU at-risk cohort, and let's say we've used the MSG criteria, and we think there's about a 10% likelihood that a given patient has candidemia. If you look at, for example, beta-glucan and T2 Candida PCR at various reported levels of sensitivity specificity, you can see in that cohort, in general, you will get positive predictive values above 30%. You'll maintain excellent negative predictive values. So in this cohort, there might be value in doing non-culture testing. However, if you look at the sepsis all-comers cohort with a 3 to 5% pretest likelihood, then your positive predictive values are going to be marginal. So the utility in the MICU for candidemia for these tests is probably going to be somewhere between all comers with septic shock and then people who are fulfilling diagnostic predictive criteria. So doing a similar exercise there in your surgical intensive care unit, looking at patients at risk for intra-abdominal candidiasis. Let's take beta-glucan. If we go across studies and sort of take a median sensitivity specificity, we think we might get value in patients who have diseases such as acute necrotizing pancreatitis, small bowel perforations, or possibly in your high-risk hepatobiliary or gastroduodenal perforation groups, where your positive predictive values get up around the 30% range, and you maintain decent, if not great, negative predictive values. So what we'd have to decide here is, are you willing to accept a 15% likelihood in your highest risk cohort that you still have candidiasis with a negative beta-glucan result? And that's something individual practitioners and units will have to make their own answer on. If you look at T2 Candida, performance in intra-abdominal candidiasis, sensitivity is a little less. Here, you may get value in some of your lower prevalence populations like emergent intra-abdominal surgery or colonic perforation. However, at your highest risk group, hepatobiliary patients, your negative predictive value now is only about 80%. So you've got a 20% chance that a negative test is a false negative, which probably means the test is less useful here. So here your window utility is going to be kind of in this 10 to 20% mid-range rather than in your highest risk cohort. So with that, let's go back to our case. We asked, what is the likelihood with a T2 positive result, negative blood and abdominal cultures for Candida, that this patient has intra-abdominal candidiasis? So that postoperative biliary leak puts him in a high risk group, probably about 30%. However, you do have negative culture results, which are going to reduce your likelihood, right? So intra-abdominal candidiasis sensitivity is about 50%. So the negative culture probably brings you down to about a 15% likelihood. The blood culture maybe reduces it a little bit more. So, with the cultures, the likelihood of abdominal candidiasis before your test is probably 10 to 15%. And in that setting, a positive result, assuming sensitivity of 40% and specificity of 95%, gives you a 50% positive predictive value. So that's probably good enough to justify the treatment that we gave to our patient. And if the test was negative, the negative predictive value is going to be on the order of 92%. So you still have an 8% chance of having disease despite a negative test. So in this setting, very strong positive predictive value. So it helped us in our patient who was ultimately confirmed on another surgical intervention to have intra-abdominal candidiasis, but realize with this negative predictive value that you will miss some cases of intra-abdominal candidiasis. So then how can we use these tests in patient care? In individual patients, it's important to realize you don't need to do all this math. You can do it more impressionistically. This is how we use the galactomannan for aspergillosis. If you're putting the test to play in the appropriate populations, the math works out and you don't need to do the calculations. The other way we can use it is in population strategy. So using it as part of antifungal discontinuation or targeted preemptive empiric treatment algorithms, where you're testing well-defined cohorts of patients using negative results to not treat or positive results to treat. And there are emerging data now from individual centers in the United States and Europe that have shown in particular these discontinuation strategies with beta-glucan or with T2 Candida in ICU patients, including those in septic shock, might be viable. Dr. Hong Nguyen at our center and the diagnostic stewardship team rolled out T2 Candida first at our hospital in the MICU, looking at septic shock patients. We did our calculations. We know 3 to 5% of our patients fitting our inclusion criteria typically test positive for candidemia. So with that, we exploited both positive and negative predictive values to put a treatment algorithm in place. And prior to COVID, here were our pilot data with the first 125 patients with sepsis in the MICU. 88% or 110 of them were negative by both a blood culture and T2 Candida. 4 patients or 3% were positive by both blood culture and T2 Candida. And then the remainder had discordant results. 8 patients were T2 positive, blood culture negative. 3 patients were blood culture positive, T2 negative. So the big question is then, what do these T2 positive, blood culture negative discordant results mean? Are they true positives missed by blood culture, or are they T2 false positives? So if you just take blood culture positive cases, our sensitivity was 4 out of 7 or 57%. In 3 patients, the T2 result was available before the blood culture, so it got patients started on antifungals quicker. If you assume that those T2 positive, blood culture negative 8 patients are false positives, your specificity would be 93%. However, on review of those cases, we determined that 5 patients either ended up having proven or probable invasive candidiasis. So if you include these as actual disease, then your adjusted sensitivity specificity for T2 was 75% and 97% respectively. We didn't see any outcome differences in our patients. However, overall antifungal utilization before and after putting the intervention in place, as well as antifungal expenditures, were significantly reduced. We're updating these data now with our experience over the past 2 years since COVID. We'll see if the trends hold. And Hong and her team have put together unit-specific interventions in the cardiothoracic ICU with LVAD patients and in the trauma ICU, which is where we see our abdominal cases. So in conclusion, non-culture diagnostics, I think for Candida can be incorporated into rational patient management strategies. The key, though, is targeting them to well-defined patient populations and knowing your test performance locally. The other key aspect is you need a team devoted to this, a diagnostic stewardship team. You can't leave it, I think, to clinicians' own devices without some guidance. Just a quick word on combination testing. They're very, very helpful if non-culture results are concordant. But if they're discordant, they can be difficult to interpret, and you may end up right back where you started. Regardless of how you're using them, non-culture diagnostics are complements, not replacements for culture. And it's important to understand, although I talked about T2 Candida here, you can take this same approach to any non-culture test for other fungal diseases or indeed any infectious disease. And, for example, recently we published a paper in open forum on Kappa, COVID-associated aspergillosis. A lot of debate about this entity, but if you actually apply diagnostic criteria, sensitivity, and specificity to at-risk cohorts, what you probably find is a positive predictive value of someone fulfilling these criteria probably does justify antifungal therapy. So you can read the case we make for that. Right now for the field, I think we need studies of diagnostic test-driven management strategies against candidiasis. The model really should be the work that's been done with galactomannan and aspergillosis. I think we need studies of stewardship where discontinuation strategies are going to prove to be very feasible, I think. Preemptive antifungal therapy and outcomes in high-risk patients is going to be very difficult, I think, to show outcome differences, but I think it will be able to show that it shortens time to appropriate antifungal therapy. And I think along these lines, as a field, we need to think about with these tests, are there new criteria for trial enrollment and assessment of outcomes in trials, something of a door criteria that might be used given the challenges in showing mortality or microbiologic differences. Finally, I'm going to give a final somewhat provocative thought. So again, the real challenge for the past decades in candidemia has been identifying this middle cohort. Who are the patients with candidemia who have deep-seated candidiasis, and how do we find these people? So you've seen the recent debates. The American Academy of Ophthalmology has come out and recommended against routine eye screening for patients with candida bloodstream infections. We just published a paper in CID making a case that there's still value to be gotten from routine eye exams. And a point we made in that paper is that the way to think of an eye exam is not merely as a test for ocular candidiasis, but actually as a diagnostic test for deep-seated candidiasis. And if you go back to the autopsy literature, here's the landmark paper published in the 70s by Jack Edwards out of UCLA, looking at autopsies from 76 patients with hematogenous candida ocular infection. And these observations have held up in the subsequent literature. You almost never see ocular candidiasis on an autopsy without other organ involvement. Most commonly the kidneys, but about 60% of patients with heart involvement, a quarter with brain involvement, and then other organs. So as you're trying to figure out what you're going to do with ocular candidiasis screening with your ophthalmology colleagues, I think this is an important point to make, that we're not only concerned about detecting the endophthalmitis or chorioretinitis, but this will identify some number of patients with unrecognized deep organ disease who probably benefit from longer course antifungal therapy. So that's the end of my talk. I'm happy to answer any questions, and you see my Twitter and my email address is there. Anything we don't get to today, please drop me a line, and happy to talk through these issues. Thank you.
Thank you, Neil, for that masterclass in Candida Diagnostics. We do have several questions in the chat. The first one is from Eunice, who's asking, is there any data on the serial monitoring of beta-D-glucan to guide discontinuation of empiric antifungal therapy?
So I should probably defer to you, Dr. Ostrowski, because you've put data out there showing that, the general trend of the slope is down. So in a general sense, decreasing beta-glucan levels are good. I think the challenge is that beta-glucan hangs around for a long time in serum, and coming up with workable algorithms that allow you to use perhaps a downtrending slope line to actually make real world treatment decisions is really, really problematic. So I would say in a practical sense, the use of that just isn't there to help you in individual cases.
Perfect. And we have a question from Dr. Sulaiman, who's asking, is it dangerous to roll out beta-D-glucan monitoring without knowing the baseline incidence of invasive candidiasis in your ICU?
Yeah, you absolutely have to know your local epidemiology. I think you have to know what your baseline rates of disease in different patient cohorts, and that's going to determine then, what your positive and negative predictive values really are and how the tests can be used and if they can be used. And at some centers, they're not going to offer value. An important thing with T2 Candida I really didn't elaborate on, but there are some centers, including in Houston at MD Anderson, where you see a lot of otherwise rare Candida species. And if the assay is not going to detect them, then a test like T2 Candida may not be useful. So always need to know your local epidemiology and put your programs together accordingly.
Provocative question from Eli Castillo. Is the Candida risk score still useful?
So my general sense is yes. One of the challenges with the Candida risk score is if you're going to include culture screening as part of that, so a Candida index, that's a lot of work, and you've got to systematically then do the screening to detect colonization. If you're going to use something like the Ostrowski score, I think within that cohort, it's very, very valuable because you will be able to identify a higher risk cohort with 10 to 15% likelihood of candidemia. However, you're going to then miss patients who are excluded who don't fall within that cohort. So it's a trade-off. And again, I think you'd have to decide where and when am I going to use it? And for me, with what I want to accomplish, is the trade-off worth it?
Excellent. So another tough question here from Dr. Verma. Given gut permeability loss in critically ill patients, is it possible that beta-D-glucan is present in sepsis patients without freely circulating Candida?
Absolutely. So I think there's a misunderstanding about a lot of the false positive with beta-glucan for precisely the reason you bring up. The way to think of beta-glucan in the ICU, at least the way I think of it, is not so much as a Candida or fungal diagnostic, but as a risk factor in and of itself for candidiasis. So if you've got a leaky gut, that's a risk factor for candidiasis. So the beta-glucan may be detecting the leaky gut rather than the presence of Candida per se. But in a high-risk cohort, the leaky gut itself may be considered almost like its own diagnostic test and does increase your likelihood of candidiasis. But I think clearly there are leaky gut patients in the ICU who do not have Candida that a beta-glucan may be detecting the leaky gut rather than the presence of Candida. Just in general, with non-culture diagnostic tests, and it doesn't matter what test it is, the higher your positivity, the more likely it's a real result, and repeated positive results are more likely to be real than single test results. So you can use that to further stratify beta-glucan results as well.
Great. Question from Dr. Michelli. Any impact on mortality since you implemented the T2 pathway in your ICUs?
No, and that's part of what I was trying to get at in one of my concluding slides. It's very, very tough in any study, a diagnostic or drug treatment study, to show mortality or outcome benefits with candidiasis. Part of the reason for that is, as we said, half of candidemia may clear even without, say, antifungal therapy. So some people are going to do well no matter what you're doing. Conversely, in this patient population, a certain percentage are going to do poorly and die, even if you're doing the right thing and even if you're making diagnostics. So the population in which you can actually show an outcome difference is some subset of your larger population. It just makes it really, really challenging in trials to show conclusive outcome data, which is why I wonder if the outcomes we should be measuring aren't so much survival, death, culture positivity, negativity, but maybe things like antifungal utilization or some sort of DOR criteria.
Well, that's all the time we have for questions. There's a few more in the chat, and we'll make sure that Dr. Clancy gets them, and
Yeah,
maybe we
please.
can
Yeah, please send them
post.
on,
Mhm.
Dr. Ostrowski. Happy to answer. And I agree with Dr. Nucci's point that most candidemic patients who die will die with candidemia rather than because of candidemia, and that's often the case.
Perfect. Thank you so much for such an interesting talk.